This project is a collaboration between OHSU, Oregon Department of Rural Health, Oregon EMSC, and Oregon Department of Transportation, who have provided funding and curriculum to put together a 2-day project that uses these high-fidelity wireless mannequins that talk and breathe, and you can place IVs and do procedures with them, and they provide vital signs, and you take them and stick them into the vehicles and sort of stress the system.
2 vehicles, 2 vans. Yes, there's blood. There's a little girl.
Somebody, she's not breathing! Help me, please!
Station 25A, this is a drill. Report of a 2-vehicle MVA with injuries across from the high school, 1001 West.
Thursday morning, several Astoria and Lewis and Clark fire departments, medics, ambulance crews, and a life flight helicopter crew collectively assisted in a full-scale pediatric trauma simulation. It began at Astoria High School at the scene of a staged accident. The call came in about 9:15 for crews to respond to a 2-vehicle collision in which 7 patients were involved. 5 real-acting patients and 2 wireless computer-controlled pediatric mannequins were used. First responders went into action working with actors and mannequins as though they were in a real-life emergency situation. Throughout the simulation, specialists controlled the mannequins with tablet computers while simultaneously monitoring the vitals responding to the work of the first responders. One mannequin was transported by life flight and the other patients by ambulance to Columbia Memorial Hospital. Teams were ready and waiting at CMH to take over the care of the patients, with pediatricians already on hand. Zachary Messberg, an EMT from Portland, helped explain the technology used with the mannequins.
What we have here is the Gamard Simulators 5-year-old HAL mannequin. And this is a high-fidelity patient simulator mannequin. So what this mannequin does is, traditionally in medical training, especially in emergency medical services training and ER training, we would use rubber mannequins. So it would essentially be this, but there'd be no computer in it. You could maybe intubate, you could put a breathing tube in, you could potentially start IVs on them, but the mannequin wouldn't do anything in response to that. You'd have what we call a proctor, which would be somebody who would stand to the side and tell you, you see this, this is what happens when you do this. And so the goal of using these kind of mannequins is to have it simulate a real person as closely as possible. So when we put a breathing tube in and breathe for it, we can change the oxygen levels that it has. We can make its chest rise and fall. If you put the tube in too deeply, we can have it so that only one lung inflates. And that's just a small example of what it can do. So you can start intravenous lines on it. We can start intraosseous lines, which is a kind of IV line, or a sort of an IV where you access the bone marrow to actually put in fluids and medications. We can do EKGs on this. CPR can be done on it, and the pupils react just like in a real individual. Depending on what level of consciousness we're simulating, it can actually speak to you to a certain extent. This simulates a cardiac monitor, pulse oximetry, which is basically a measurement of the amount of oxygen in your blood. It can simulate a respiratory monitor, and it can simulate other monitors depending if we were doing critical care scenarios. You could do invasive blood pressure, for example. You could simulate invasive temperature monitoring, which we're not doing for the purpose of this scenario, but you can change the configuration of this. So basically, this is the controller. You always need to have this in place, but like I said, this is optional because if, let's say we were simulating a basic life support EMS scenario where they wouldn't have monitoring, we wouldn't have to have monitoring. So, as you can see, the cardiac monitor is going. We have pulse oximetry reading, so we are simulating that his somewhat hypoxic levels of oxygen are lower than probably they should be, not super low. We have a respiratory rate simulated, a temperature, and a blood pressure. And as you can see, now that he's on, he's actually breathing.
Afterwards, the many involved met for pizza and a debriefing about the events that unfolded, discussing both positive and negative aspects of the simulation. The debriefing was mostly positive. However, certain aspects about communication between departments and with the hospital were raised, in which there was room for improvement, as well as the time spent in the scene. The simulation was coordinated by Oregon EMS for Children in conjunction with ODOT, Life Flight Network, Columbia Memorial Hospital, medics, and local police and fire departments. For more information on this project, visit OregonEMSC.org.